Hello, I'm Adrienne Fu Berman. I'm director of Farmed Out, a project at Georgetown University Medical Center that advances evidence-based prescribing. I'm a professor in the Department of Pharmacology and Physiology and also the Department of Family Medicine here. Welcome to our module on MCI and Alzheimer's, First Do No Harm. Today we're going to hear from Dr. Susan Molchan, Dr. Tracy Lippard, and Dr. Peter Whitehouse. So Dr. Molchan and Dr. Lippard will give brief presentations, and then Dr. Whitehouse is going to comment on those presentations, and then we'll have an open discussion among our three participants. Here's the faculty who are involved with the module. And here are their conflict of interest disclosures. Here's some additional information about the module. Thank you so much for choosing the CME activity, and I hope you enjoy it.
I'm going to talk about what's meant by the term Alzheimer's disease as it's generally used in our society and the world today, and how the meaning has evolved since the condition was given a name in the early 1900s. So some history to include how it's been diagnosed over the years, as well as how research and attempts to address cognitive decline have developed. So we're talking about dementia, just to talk globally, which is loss of cognitive or intellectual abilities, such as memory, severe enough to interfere with daily functioning. So traditionally, for the past 40 years ago, we've been taught that most dementias, at least 50 to 60%, are caused by Alzheimer's disease. 15 or so percent are caused by vascular dementia or blood vessel disease, about 6% by dementia with Lewy bodies, and about 1% by a group of dementias called the frontotemporal dementias. And then there are dozens of other pathologies and contributors to the rest. In reality, most dementias are a mix. Most people with dementias are in their 80s. They've accumulated a mix of pathologies in their brains. Just like everywhere in our bodies, our eyesight declines, our hearing, skin wrinkles, arthritis, in our low backs and our knees, things decline as people get into their 80s and 90s. So Dr. Alzheimer, who is shown here on the right, his first case was a woman in her 50s. She looks much older here, and her brain looked older still. She had memory impairment that worsened very quickly over the few years that he knew her. She also had paranoia, hallucinations, other neurological and psychiatric symptoms. But Dr. Alzheimer didn't necessarily think that her case warranted a separate disease classification. He thought that she looked like she had senile dementia, which was the term used at the time for older people with dementia. But he collected a few other cases of relatively young people with this degree of memory impairment who looked ill to the point like they also had senile dementia. His lab chief at the time, his supervisor, who was big into classification and claiming scientific and political turf, essentially laid claim to these cases and did go ahead and name them as a separate disease. It's a little more complicated than that, but that's essentially it in a nutshell. What made Dr. Alzheimer's cases especially interesting was that he described the pathology in the brains of his patients. When he looked under the microscope, he could see these big blotches of, he wasn't sure what they were, but he called them amyloid plaques. Those are the large splotchy things with the arrowhead pointing to them. And inside the cells, these little flame-shaped things with the arrows pointing to them, neurofibrillary tangles. The tangles are abnormally processed proteins that make up microtubules in cells. Over time, we came to learn that both these things occur in normal aging. We all get them, whether we get memory problems to any degree or not. The amyloid plaques, especially, can occur in quite a large amount in the brain of people who don't have problems with their memory. The tangles occur a lot in lots of other diseases, especially the frontotemporal dimensions, which we call the tauopathies now. as the 20th century progressed, lifespans increased as people stopped drinking water from their sewage, basically with improved sanitation, housing, and education, antibiotics, vaccines. In the 20th century, more people lived into their 80s and 90s. This had never happened in the history of the world before. Age being the biggest risk factor for dementia, we saw a lot more of dementia cases. Also in the 20th century, we know that technology boomed on all fronts, including in science. Researchers had many cool tools that they could use to delve deeply into cells and even into genes. They could clone and sequence genes, put them into animals, have the animals developed the amyloid plaques, the tangles, have the animals develop cognitive impairment, cure the animals of the cognitive impairment many times over. Many papers were published, careers made, startups, many of them, millions of dollars were made, but nothing really developed to help any patients. Neuroimaging technologies took off. This is an example of amyloid PET scans, which people became very excited about. The red areas at the top are deposits of amyloid. And again, this person could have memory impairment or not. We all get amyloid in our brains, and people can walk around with quite a bit of it and have perfectly normal functioning. The lower slide has red with a more kind of normal amount of amyloid, which we still don't know quite, what is the function of amyloid. But regardless, cool tools, expensive tools. So in the 70s, scientists understandably wanted to use these things to study more about the brain. It wasn't going to fly just to say they wanted to study old people or senility. At the time, Alzheimer's disease was still used to refer to the early onset dementia, those with memory problems for which no other cause could be found when they were 65 years old or younger. That is a familial condition, genetic, in a few thousand or so families. It accounts for less than 5% of dementia cases. But in the 70s, a few scientists said, well, let's bring everybody into the Alzheimer's fold. Anybody we can't find another cause for their dementia, that hasn't had a significant degree of vascular disease or other problems that we can't find a cause for their dementia. We'll call it all Alzheimer's disease. So now they had a disease, they had a focus with which to bring in research dollars. The NIH even established a new institute for this, the National Institute on Aging. Not that this was all a bad thing by any means. In and of itself, too many people at the time with dementia, still called senility, with memory problems were not given an adequate workup. They were kind of maybe pushed aside too quickly, where some of their problems could be due to reversible causes, or some of them could have been treatable. And we look for all that now. We look for low thyroid, for low vitamin levels like B12, for sleep problems like sleep apnea. We look for depression that can look very much like dementia in older people. And we look for drug side effects. So this was a good thing in terms of calling more attention to dementia. But on the other hand, the marketing machine for Alzheimer's disease was born. Organizations like the Alzheimer's Association tried to make sure people were more afraid of getting dementia than of getting cancer, using statements saying that 1 in 10 people age 65 and older have Alzheimer's dementia. I think they have actually 11% now. And that may be true. But as I said earlier, most people with dementia are in their 80s. So focusing on people in their 60s is a bit misleading. To understand the prevalence more clearly, when you're 65, you have a very low chance of having dementia. And the studies show that prevalence at that age is quite low. that the prevalence at age 65 to 74 is 3%. So that puts it in a more realistic perspective. Other statements, they like to compare deaths from heart disease and cancer. All of these, breast cancer, prostate cancer, heart disease, have been decreasing. What happens when these diseases also that happen in older people, what happens when these decrease? People survive these illnesses. These are success stories. These are medical success stories. People live longer. They get into their 80s. Age being a risk factor for dementia, more people die with Alzheimer's disease. But this is used to imply that dementia is a neglected area of research. Again, not a very useful statement to make or honest statement to make. Another example, if you look, this was from the Alzheimer's Association website this week. Again, most people with dementia are in their 80s, but the people depicted are often much younger looking than that. Again, there is something called early onset Alzheimer's disease that affects a few families, but the depiction of dementia on websites and in the media, we often see people who are in their 40s and their 50s, which is not a realistic picture. The first director of the National Institute on Aging called it the politics of anguish. It's a good way to raise money. So when you have a disease with lots of technology and you need to keep the ball rolling, you need to find a cure. No matter that people have to die of something and everything wears out with age, that's not to say everybody gets dementia as they get older. They certainly don't. And we all hopefully have seen this. People into their 90s with all their marbles. But by the time most people reach the age of 100, the chance that we'll have dementia, memory problems that interfere with our activities of daily living is a bit over 50%, maybe approaching 60%, but that's still pretty good. Doing something about our health in our place and time, unfortunately means drugs for the most part. Especially now that we have what I call an Alzheimer's industrial complex that over the years has come to fund most of the research in Alzheimer's disease and gives money in the form of grants or advisory fees to most of the academics, at least those in clinical research in the field. In the 70s, many scientists focused on deficits of the neurotransmitter acetylcholine in people with dementia or Alzheimer's disease, even though there were deficits in other neurotransmitters. They hoped that boosting acetylcholine, which is involved in attention and memory, would be helpful, just like boosting dopamine in Parkinson's is helpful, at least for a time. It was a good idea. It was a good theory to test. Billions of dollars were spent on a class of drugs called the acetylcholinesterase inhibitors. They're still prescribed today, although the magnitude of their benefit continues to be controversial and is generally considered minimal, and in a minority of patients diagnosed with Alzheimer's disease. Not that it wasn't worth a try, but the most commonly prescribed one is Aricept or donepezil. Unfortunately, with marketing hype, fear stirred up about dementia, and payoff of those in academia, these drugs are still heavily used. As we came into the 90s, we had a new target. Research on amyloid dominated the field as the gene for it became identified and sequenced, and a number of genes involved in early onset Alzheimer's were found to code for amyloid. Amyloid provided a great target that drugs could be designed around, and many, many drugs were. Billions of dollars were spent with nothing to show for it. In the meantime, what we mean by Alzheimer's disease has continued to change. The idea being that the earlier something is diagnosed, the better to treat it. The common explanation for why none of the drugs were working was that they were being given too late. So scientists developed the concept of mild cognitive impairment, or MCI, thought of as a pre-Alzheimer's condition, where people would have problems with their memory or organization, for example, but not to the point where it was really interfering with their activities of daily living. So mild cognitive impairment started out as a construct in research, but now it's gone quite mainstream. And even though many studies have shown that people diagnosed with it, which is done through memory testing, people diagnosed with it revert to normal a good 30% of the time, and many do not develop dementia over the ensuing several years of being followed in studies. Studies have also found that education is protective. That is, one is especially likely to revert the higher one's educational level. Let's remember that it is normal to have things wear down with age, including memory. It's well documented that our cognitive performance is that generally peaks in our 30s. Over time, it takes longer to process things. Our working memory gets a little rustier, not quite as much sticks. As we get into our 70s, the ability to abstract and pull together lots of concepts goes down. Again, it's different for everybody, depending on a lot of factors. The biggest pot of gold for those who would like to get millions of people to swallow a pill every day or take an infusion every month for years and years is to have a scan or ideally a blood test that would predict who would get Alzheimer's disease years before any memory problems. The problem is with this, again, is that dementias, most of them are multifactorial, and the biggest risk factor is age. I think Dr. Lepard will talk about those risk factors. But how realistic is it to think that swallowing a pill for decades is going to inhibit some sort of pathology in the brain, and again, remembering that all drugs have side effects. Speaking of side effects, we've heard a lot about, in the past couple of years, a drug called aducanumab, brand name Aduhelm from the company Biogen. It's a monoclonal antibody that's been developed to bind to amyloid and not let it deposit as plaques. Though we don't know that doing this will slow down dementia symptoms, we do know that it has side effects resulting in brain damage, specifically little microbleeds of the brain and brain swelling. I'll just say that the approval of this drug by our FDA against the recommendations of their own advisors, contrary to the scientific data, contrary to the decision of the European and Japanese drug regulatory agencies, which did not approve the drug, is a sad and outrageous piece of the history here. Thank you.
Hi, everyone. I'd like to introduce myself. I'm Tracy Lepard. I'm an internist and a geriatrician, and I practice at Kaiser Permanente in Colorado. I am a practicing physician. I see patients a few days a week, and I'm also serving as the director of complex needs, community health, and government programs for Kaiser Permanente in Colorado. And I serve as the physician lead for both elder care and complex needs at the Care Management Institute at Kaiser Permanente nationally. And I'm just delighted to be here today to discuss this important topic of dementia. So every day in clinic, I see patients and families affected by dementia. And today I hope to provide you with some practical ways to think about dementia prevention and treatment. I'd like to walk through the Dementia Prevention, Intervention, and Care 2020 report of the Lancet Commission. It's filled with really helpful information, and I'm going to touch base on some of the highlights, but I really encourage you to take a look at this if you can. I find the life course model for potentially modifiable risk factors for dementia to be a helpful framework in thinking about dementia prevention. This includes 12 things we can do as individuals and as a society to prevent or delay up to 40% of dementias. Some of these factors act by reducing neuropathological damage to the brain. This includes things like treating hypertension, minimizing diabetes, preventing head injury, not smoking, reducing air pollution, and reducing obesity. And some of these factors help to increase and maintain cognitive reserve. This includes treating hearing impairment, maintaining good social connections, and attaining a level of education. Some may act in both ways, by both reducing those neuropathological damages and by increasing and maintaining cognitive reserve. And that includes exercising, treating depression, and avoiding excessive alcohol. This 2020 Lancet Commission is an update to their 2017 commission, and there are 3 new modifiable risks that were added based on newer evidence, and this includes excessive alcohol consumption, head injury, and air pollution. We should be ambitious about prevention. This is about both policy and the things we can do as individuals. It's never too early or too late, and modifying these 12 risk factors, as I said earlier, might prevent or delay up to 40% of dementias. When looking at the life course model, we must recognize that the risks for dementia are not distributed equally. The attributable burden of dementia and excess death from air pollution in a large 10-year United States study was particularly high in Black individuals and socioeconomically disadvantaged communities. Our zip code is more powerful than our genetic code when it comes to our health. The Robert Wood Johnson Foundation has a really nice interactive website where you can actually enter your address and see how striking this effect is. Where you live affects how long you live, and even short distances between neighborhoods can be associated with a large gap in life expectancy. The United States invests far more in clinical services than it does in addressing social and behavioral factors that affect health and mortality, compared with other high-income nations that really enjoy better health than we do. Population-based strategies for reducing risk of dementia includes policies that promote and prioritize childhood education, access to healthy food, assuring safe places to play and exercise, safe work environment, reducing air pollution, and ways to reduce smoking. There are also individual things that we can do to reduce the risk of dementia, and these include treating hypertension, especially in midlife, encouraging the use of hearing aids for hearing loss and making those more affordable, avoiding or discouraging drinking more than 21 drinks per week, and I would say probably less than that for most women. Prevent head trauma. Stopping smoking is beneficial at any age, and reducing obesity and the linked condition of diabetes by healthy food availability and an environment to increase movement. And of course, encouraging regular activity. Dr. Eric Larson is a researcher from Kaiser Permanente in the state of Washington, and he wrote a really nice editorial in the Annals of Internal Medicine in 2018 that I find particularly helpful when patients ask me what they can do to prevent dementia. While many people wish it was as simple as taking a supplement, there is no magic bullet, but there is lots that we can do, and these include maintaining regular physical activity, maintaining a healthy diet and healthy weight, controlling vascular risks, including preventing or effectively managing diabetes, not smoking, engaging in cognitively stimulating activities, staying socially active, correcting vision and hearing loss, and avoiding drugs that harm the brain, such as chronic high doses of anticholinergics. Now I'm going to shift gears a bit and talk about the treatment of dementia, because even if we do everything we can to prevent dementia, some people will develop late life dementia. And in my mind, well-being should be the overarching goal of care in dementia. For people with dementia, recommendations should include holistic post-diagnostic care, managing the neuropsychiatric symptoms of dementia, and caring for caregivers. Quality dementia care should be individualized, comprehensive, dyad-centered planning, including the caregiver, and will obviously need to change in response to the stage of dementia as the disease progresses. It should include medical and financial planning really as early as possible so that we can include the person with cognitive impairment to the extent that they can participate. People with dementia often have other chronic diseases. They usually have other chronic diseases, and it's important to continue to care for all of those things too, which may well include caregiver support and medication reminders. And minimizing polypharmacy and pill burden, especially that any medication that is harmful to cognition. The list is long. There are so many medications, but anticholinergics and benzodiazepines are always top of mind when I think about this. I love this quote from Voltaire. Voltaire was a French writer, a historian, and a philosopher. And his observation from the 1700s is still very much true today. Physicians pour drugs of which they know little to cure diseases of which they know less into humans of which they know nothing. Wise words. One of the things I try to impress on residents and medical students working with me is that when someone comes in with any concern, always ask, could a drug be causing or aggravating this person's problems? I find this particularly true in patients with dementia. Just yesterday, I saw a patient in follow-up after an emergency department visit because of fatigue and increased confusion. Thankfully, her workup there was unremarkable and she was sent home. In follow-up with me a few days later, yesterday, I uncovered that she had for a few days actually been taking an over-the-counter cold medication containing diphenhydramine to help her sleep. And so talking with her and with her daughter, making sure that that medication will be removed from the house should help to prevent these kinds of things in the future. Quality dementia care should also include encouraging physical activity, maintaining social connections, a healthy diet, and daily routines. I am struck by how often I have seen a decline in memory and impairments over the past couple of years of the pandemic. And I think that that really speaks to the importance of social connections and not being socially isolated. Environmental strategies are often very helpful as well, supportive things such as clocks, calendars, to-do lists, and visual cues. It's important to structure activities to match the ability of the patient. A lovely illustration of this is one of my patients and her caregiver have always enjoyed doing puzzles together. And as her dementia has advanced, she can no longer do these big 1,000-piece puzzles that they've always enjoyed doing. And so the caregiver will complete a 1,000-piece puzzle, and then he'll strategically remove maybe 10 puzzle pieces and have the patient sit down and complete the puzzle with a little encouragement. It still takes her a bit of time to do it, but she gets such a sense of accomplishment, and they both get such joy from still being able to participate in something like that together. And then as dementia progresses, caregivers in particular need to be attentive to safety issues. People with dementia are so susceptible to telephone scams. They need help remembering their medications. And then things such as driving and when to stop driving, securing firearms, dangers in the kitchen, and wandering are all issues that need to be addressed. In terms of the neuropsychiatric symptoms of dementia, I think it's really important that we help train caregivers to look for underlying causes because they really can help with this. I counsel caregivers to make sure they're thinking through things such as pain, discomfort, hunger, loneliness, boredom, even just being a comfortable temperature. Maybe someone's waking up a bit chilly in the night and just an extra blanket can make a difference. Reduce overstimulation. Quiet music is much better than loud TV for the person with dementia. And then using disease appropriate language, I think is a skill that some caregivers kind of come to naturally and by instinct, and other people really need some support in learning this. But it's really important to have simple, concrete terms and familiar words in a really warm, easygoing, pleasant manner, because people with dementia are often extremely aware of nonverbal signals, such as facial expressions, if you look angry, body tension, and mood. I think it's important to make sure that caregivers understand that we should avoid reasoning. Instead of saying something like, where do you think you're going this time of night? You can't leave by yourself. Say, before you go, could you help me in the kitchen? I'm going to make some tea, and use that as a distraction technique. Instead of saying, I just told you your appointment's at 2, say something like, don't worry, I'm going to, and I'm not going to leave without you. Instead of saying, no one is stealing the jam from your fridge, say, are you almost out of jam? I'll pick some up for you in the morning. And learning some of these scripts can be so helpful for the caregiver to de-escalate the situation and just know how to handle things a little bit more gracefully. And of course, we know that psychotropic medications really lack much efficacy, but show clear evidence of harm. And so we really want to try to avoid using medications to manage these neuropsychiatric symptoms if at all possible. Family caregivers need support. They provide a tremendous amount of care, and they often aren't included in the care planning or given adequate education and training in the tasks they are being asked to do. Family caregiver support should include planning for emergencies and for backup support. If the caregiver ended up in the hospital with an appendicitis, what would happen? They need to think through these things and have that backup plan. education and anticipatory guidance is so helpful. And I think it just needs to happen along with the trajectory of the illness. We can't overwhelm people with too much initially or at one time. We really need to give them timely recommendations. People need to know where to go for help when they need it. Having some respite is very important for the health and well-being of the caregiver. I have a story of one of my patients with moderate dementia. I saw her and her daughter with whom she lives in January. And in January, the daughter was really stressed out. She was clearly not doing well, handling the many caregiving tasks that she had to do, and she was feeling a bit overwhelmed. When I saw them in February, the whole vibe changed. And I asked, what was the difference? And they had recently hired a caregiver. Actually, this is through one of the benefits that they were offered through their plan at Kaiser Permanente. And the caregiver, non-medical caregiver, happens to be a college student, pre-med college student at a local university. And she's coming in 4 hours a day to provide a little support for the member with for the patient with dementia. So in those 4 hours, the daughter can go out, she can have coffee with friends, she can exercise, she can go to the grocery store. She just has a little space to do the things that she needs to do. And the other interesting thing is that the patient has always enjoyed cooking, and she's actually spending these 4 hours doing kitchen projects with the caregiver. And recently they had made Valentine's cookies together. So it's really just such a great opportunity for the patient, for the daughter, and I would say for the caregiver, who's probably learning some really great skills doing this. I also think that gratitude, it's clearly not enough in itself, but simply acknowledging people as caregivers and thanking them for what they do is meaningful and appreciated, and we can't forget to do that. So improving care for people living with dementia and their caregivers, I think, needs to include a lot of things from an individual level to a policy level. We should make sure that we're uncovering and addressing non-medical needs through close and supportive relationships with community partners. Make sure that we're identifying caregivers, that we know who they are, and that we're providing them with appropriate education, training, and supportive services as they need. Promote policies to support total health and well-being, including social and behavioral needs and support for caregiving families. And finally, one of the most important things I think we can do is ask patients and caregivers what matters most to them and make sure that we're aligning care with these goals and priorities. Thank you so much.
Thank you so much for those great presentations. And now we're going to hear from Dr. Peter Whitehouse, commenting on the presentations.
Well, yes, absolutely. Thank you, Tracy and Susan, for those presentations, and Adrian for inviting me to be part of this important program. I think the work of Farmed Out is just so important, so I'm delighted to be here. I'm going to divide my comments into diagnosis, treatment, prevention, and care, because I think as we see, those are the areas that Susan and Tracy covered. I'm a geriatric neurologist at Case Western Reserve University and the University of Toronto, and I've worked in all those domains myself. Susan told us some of the historical confusion behind the term Alzheimer's disease and mentioned the word mild cognitive impairment. She also mentioned that people constantly ask us about the difference between dementia and Alzheimer's disease. That's a question I've been getting for 30 years. And why is it the case? Is it the people just don't listen to what the experts say, or is it that the experts themselves are confused? I believe it's that latter answer. The concept of Alzheimer's has changed over time, from the time when Alzheimer was describing it in a younger person to now experts who don't want to talk to patients. Basically, they just want to diagnose Alzheimer's disease by biomarkers that haven't been validated. And it's getting worse with this diagnostic creepiness, as I call it, because we've not only got mild cognitive impairment, which is a research concept that came out into clinical practice far too early, as Susan said, but we've got subjective cognitive decline. All you have to do is complain your memory is getting worse, and you've got that label. And by the way, the Alzheimer's Association, which has been doing terrible work in this space, has been promoting this concept in public health spaces, educating public health officials about people complaining about their memory as they get older. My, is that the most important public health problem we have? Absolutely not. Susan also mentioned treatment. Yes, I did work on the cholinesterase inhibitors early on, and I have to say they've been disappointing. What can I say more? But aducanumab and those drugs have been even worse, because basically our FDA has been co-opted. This drug should never have been approved. The biomarkers were not validated. And CMS, fortunately, did very creative work jumping in and saying, look, we need more data. We need to determine whether these drugs are valuable for patients. This is a huge issue in medicine in general, that the pharmaceutical industry, allied with co-opted lay groups like the Alzheimer's Association, US Against Alzheimer's, are promoting things that they say meet the needs of patients, but they don't. They meet their needs, not the needs of patients. Now on to Tracy's important talk. Wow, that was great too, Tracy. First, yes, it is about public health. It is about, Tracy mentioned air pollution. We could mention lots and lots of other things. For example, we could mention lead. This is back in the equation. We got it out of paint and we got it out of gasoline in the 1970s, but now it's in our water. Cleveland, where I live, has more lead in the water than Flint, Michigan. And so this idea that we really could be making a difference if we worked on nutrition and exercise and safe neighborhoods and all the things that Tracy's mentioned and more. The Lancet Commission is quite right. We could reduce dementia considerably if we just attended to those kinds of conditions, and that would help all of us with whatever ails us. The trouble is you can't make money out of public health, although some people try to. And then Tracy went on to care. And I have to say, there were some lovely pearls there. I have to say, my wife loves jigsaw puzzles, and I don't particularly. The idea that she would finish the jigsaw puzzle and allow me to come in and finish it off. Well, that was a great little technique to use with people with memory problems. But more than that, the groups that say care today, cure tomorrow. Sorry, cure today. Yeah, care today, cure tomorrow. See, I got to confuse myself. It's nuts. What do they think? We're going to cure all these conditions and not have to care for each other anymore. So this focus on improving long-term care, thinking about community long-term care, thinking about the role of arts. I'm part of a group called Reimagining Dementia, which started during COVID when we really saw how bad long-term care can be, particularly for people with dementia. So these two talks took the range all the way from diagnosis to drug treatments, with a critical stance there from Susan as appropriate, into where we should be spending more time talking about things, which is Tracy's talk on the public health and care aspects of this condition. Now, I hope that those were sympathetic comments, but I'm certainly looking forward to my comments to the conversation between us all now. Thank you very much again for inviting me.
That was wonderful, Peter. And now I'd just like to open it up for discussion. And I have a few questions to get us started. But my first question is there an epidemic of dementia? Have rates gone up or down over time? There seems to be this perception that there's really an epidemic of dementia.
Right. Well, could I jump in on that one? Because that's the question that motivated our book, American Dementia, Brain Health in an Unhealthy Society. And the fact is that you don't hear this from the Alzheimer's Association, but the rates of dementia in North America and Western Europe have been going down. There are now half a dozen studies that show that. By that, I mean that your risk at a certain age is less. Now, there are more older people in the world in general, so that the absolute number of people with dementia is going up, but the rates are going down. And we don't know exactly why, but it's probably for what Tracy was saying, that in the 1970s, we invested in clean air, clean water, educating people, and we essentially had a democracy in the United States and North America and Western Europe that was taking those public health issues seriously. We got lead out of the water, for example, what I said before. So I actually think that's a hugely important message to spread. It's a great first question, Adrian, because if we work hard, we can reduce rates of dementia. We're not working hard by spending a lot of time and effort on single molecular reductionistic drug approaches.
I'll jump in on this too. Eric Larson wrote a great article just on this. Is there an epidemic of dementia several years ago? And one of the points he made was the aging population, right? There is more dementia, but as Peter mentioned, in Western countries, the dementia rates are going down. And that most dementia is in people in their 80s. People are living longer, and most dementias are mixed. They are due to not just what we call due to amyloid deposits, they're due to blood vessel factors, they're due to all kinds of things. Then to think that one drug is going to be a silver bullet to fix all this is just not realistic.
Yeah, and I would just add that, while we're certainly seeing a decline in age related incidents in Western countries, we also really can't necessarily make that a statement for populations that aren't doing as well from a socioeconomic standpoint, from a, just the healthy environment standpoint. And so, I mean, I really think that we have so many opportunities in that space to make things better for everyone.
Is cognitive impairment overdiagnosed?
I'll, I'm happy to start this one. I think that in some ways it's overdiagnosed, and in some ways it's underdiagnosed. And let you kind of think about what I'm saying. So I definitely see patients in my practice who have advanced dementia, and it is nowhere on their problem list or in their chart. And I think it reflects a discomfort among a lot of primary care doctors to actually make that diagnosis and put it in the chart. And so I do see some underdiagnosis. I also see kind of the flip side of overdiagnosis in people who are actually just pretty healthy, normal aging, worried well type of folks who have asked for memory testing and received it and been given a diagnosis of mild cognitive impairment when they really don't have really any functional issues. And if you really talk to them and get their history and get a little collateral information, it's obvious that you know forgetting where you put your keys once in a while or having trouble coming up with that name right when you want it is not a worrisome sign for most people. And so I think that it kind of goes both ways. In my practice I've seen both.
Mhm.
Yeah, I agree. But focusing on the overdiagnosis part, I mean, the annual Medicare evaluation has been touted as a great thing because clinicians are required to identify any intellectual impairment. Pretty much soon, being normal will be either rare or a disease, one way or the other.
Mhm.
Yeah, I would say that, the USPSTF is really very clear that we should not be just screening everybody for cognitive impairment. And I think that when people bring up concerns, it's worth hearing those concerns and thinking about doing some screening if it's appropriate. But we shouldn't just be taking everybody off the street and doing cognitive impairment screening on them.
So why not?
It's just not accurate to do so. Even if someone is diagnosed with mild cognitive impairment, about 30% a year later will not fit the criteria for that. There's lots of reasons to have some forgetfulness and even to have mild cognitive impairment. It could be a drug side effect, it could be some depression, it could be other things besides an impending dementia.
And how worried are you about, I guess, so-called pseudodementia caused by drugs or depression? How do you tell the difference between depression, dementia, and the results of polypharmacy?
I think stopping the medications is like, my favorite thing to do as a geriatrician. It's always the right answer in a geriatric board exam is to stop the medication.
Right. Yeah.
So I think that if you really take a careful history and look at the med list, including over the counters, get rid of the anticholinergics, get rid of things like benzodiazepines, and then see what happens, you'll be amazed at how much of dementia is reversible. I also think that routine screening for people who have memory concerns with a PHQ-9 or some sort of standardized depression screen is really important, because I certainly see a lot of people who have depression, and until you really adequately address that, we're not going to be able to get a clear picture of what's going on with their cognitive status.
I mean, I've done more good in my practice taking people off medicines and putting them on medicine. So I love the geriatric concept of polypharmacy. Geriatricians had to create a disease label to correct the problems of other physicians. And the other thing I would say, I wouldn't, the term pseudodementia has kind of gone out because it is cognitive impairment. It is a dementia. It's not really pseudo. In, that goes back to old, concepts of organic and inorganic brain syndrome and stuff like that. So call it a dementia and then evaluate it.
Agreed. As a geriatric psychiatrist, the same thing. I can't tell you how many people have said, just from removing medicines, you've given me my mother back. People have moved from nursing homes back into their apartments with their spouses because they were able to function, have their memories back and their cognition because they were on just too many drugs, or their depression just wasn't being treated.
Yes, I certainly had that experience a lot too. Is there a place for drugs in treating dementia?
So with regards to drugs for so-called Alzheimer's disease or conditions in which the cholinergic basal forebrain is affected, that includes other conditions like Lewy body dementia and Parkinson's. Do the cholinesterase inhibitors work? Are they worth it? That's a different question. I think that the science says that acetylcholine is important for attention and memory. We were just talking about how drugs can make memory worse. Often those are anticholinergics, the drugs that Tracy takes people off and I take people off. Do the procholinergics, do the ones that enhance acetylcholine really work? I think the answer is scientifically, sometimes a little bit, but they're not worth it. I'm very disappointed in how efficacy in trials did not convert, as it sometimes doesn't, into effectiveness in larger populations. Did I try them? Would I offer these to patients? Yes, but I would have, some caveats, particularly because they have side effects. The last thing you want is an older person to develop GI upset or diarrhea, for example.
There are other drugs that affect amyloid coming down the pike, so I'm sure we're going to be dealing with this. And do you think that any amyloid, any drug that reduces amyloid is going to be successful in terms of treating Alzheimer's or other dementias?
I worry that it might not be. I think that it's certainly worth continuing to research and study, but I really do think that a lot of this effort and energy and money is misplaced. I think that we know so many things that we could do to make lives better and to delay or prevent the development of dementia earlier on. I really think that you have to be an upstreamist in this condition, and I worry that once people have symptoms, it's really too late. And any drug that we develop that really is tackling things at that stage just isn't going to be terribly effective. That's my take on it.
So I am enough upstream that we have to start thinking about the brain health of kids, which is why I keep coming back to lead. If you want to prevent late life dementia, you take care of kids, make sure they wear bicycle helmets and don't play too many contact sports. So I agree with you there. I also had alluded to this fact that Susan did as well. If you think Alzheimer's is not one thing, it's heterogeneous. How many cures do we need? How many drugs do we need? And of course, the experts start talking about panels of biomarkers and cocktails of drugs. It makes you sick thinking about the costs of those things, and the unlikelihood that they would actually be effective. The problem with these drugs that Adrian mentioned is they are saying they've got some clinical signals, but of course, aducanumab did that as well, that way. The issue is, are they minimally clinically importantly different? This concept of MCID, and even if they were, as Tracy said, are there better things to spend our money on? This is the problem with American healthcare. They just think the next drug is going to be the best drug. It's going to make me the million. It's going to get me the Nobel Prize. Meanwhile, we're ignoring all these things that Tracy mentioned that we should be doing now.
I agree. I mean, they have been studying amyloid drugs for, I don't know, Peter, 30 years at this point, at least 20 years. I know they all have slightly different mechanisms. I never thought that they were the answer. I became frustrated when I was at the National Institute on Aging that it was such a overwhelming focus of the research funded by the Institute, to think that there was this one target that was going to fix so much of dementia in older people. I didn't think it was realistic. It was never proven that it still isn't, removing amyloid is going to fix the memory problems. And so no, and as Peter alluded to, and as Tracy, that's the problem. That's why we spend so much on healthcare, more than anybody, but have a much less healthy population. Death rates increased again this year. We're getting less and less healthy for more and more money spent, and that's because we neglect public health and the front end of things, and we put all this money into these tiny little incremental things, like these drugs that we're talking about.
So you all seem to be on the side of care rather than emphasizing care rather than cure. What kinds of tools and strategies can healthcare providers provide to caregivers to help them deal with patients with dementia?
I see this every day in my practice, and I think that really acknowledging caregivers, being able to like even identify them in a patient's chart is really important, and something that's missing from a lot of today's electronic health record systems. And I think that, you know, really making sure that we're providing just kind of just in time education and support. We can't overwhelm people like too quickly. This is a long-term chronic illness that has different stages to it, and really being there along the journey to support people and to help give caregivers what they need and connect them to resources, I think is really important. And in my mind, that is bread and butter primary care. You know, not just with a physician, but with a team. You know, with the nurse, with the social worker, with the clinical pharmacist, to help do some of that deep prescribing work. And I think that, you know, this is how we really care for people best over the long haul.
Mhm. I agree, Tracy. I both as a geriatric psychiatrist who dealt with these kinds of patients for years, as well as a caregiver who helped with both my parents who had dementia for years, fortunately in concert with my sisters. Some of the examples you gave in types of responses to diffuse situations, it's amazing how many people try to explain things to people with dementia, try to rationalize with them. And I would see this time and time again, and do just what you said. Well, no, this is a better way to put that, you know, to try to not to infantilize them, but just like with a child, just divert their attention. Don't try to explain and correct them. But it's amazing how, you know, they just need to be told, you know, what to say. It's given a script, those types of things. And just so many people don't know that. So
I think the most important thing is to not dehumanize people with the label. And that's the problem. The label dehumanizes. For example, I don't like the word caregiver because I don't like to diagnose one person as having dementia and in the same breath essentially diagnose the other person as a caregiver.
Yeah.
You need to create opportunities for the person who has the memory challenges to also be a caregiver. To be a carer or a care partner. See, I rolled up my tongue inaccurately. In our intergenerational public schools, people with dementia volunteer one-on-one to read and share stories with kids. Everybody needs a sense of purpose in life and a sense of joy. And the label just robs people of so much of that. And then, you know, so going to art museum, listening to music, dancing, all those kinds of things should be encouraged. Social prescribing of dancing, great thing, because, and yet we ask for studies, you know, does music help people with dementia? We don't need to answer that. Dancing and music help everybody. Dementia is in everybody. Therefore, you know, let's make these available for everybody.
Peter, that's so great. And I just have to share that yesterday I had a resident with me in clinic, and we saw a patient who showed us how to jitterbug. And I thought that was like one of the best experiences for all three of us. It was great. Totally agree with you.
Can you address the issue of preclinical Alzheimer's, the idea of diagnosing people based on amyloid plaques on imaging scans, even if there is no cognitive impairment? Can you talk some about that?
And they've talked about that. That's with doing some of these studies prior to any symptoms at all. All of us here, except for those maybe under 30, have amyloid in our brains. We just do. And some people can walk around with quite a head full of amyloid and do just fine, even in their 90s. And that's the thing. There's more than one thing going on in the brain besides just amyloid. And depending on the individual, cognitive reserve, their education level, other health factors, some people can do just fine with a lot of amyloid in their brain. So we're not treating, it's not like a brain tumor or an abscess that's clear, yes, this person has a disease, has a problem. So it's on an individual basis like that. It doesn't work that way unless perhaps somebody has a family, the early onset Alzheimer's cases, which is a very minority of people with the what was originally described as Alzheimer's disease, kind of the familial genetic type, which is a few percentage, a small percentage of cases of Alzheimer's disease. That might be a little different. They are almost 100% likely, almost 100% certain to get Alzheimer's disease, and that's a separate category of people. That's a different ball of wax. We're talking about what, most of us who are going to get older, we all are going to get neurofibrillary tangles in our brains as well. So we're not there yet.
So Susan's quite right. In fact, watch out, there are now amyloid blood tests that are being promoted. So then you would just get be even simpler.
Any other issues or thoughts that you have or advice for clinicians that you want to convey?
So I'm going to say one thing that both Susan and Tracy said. That's teamwork. This is a CME program for physicians. The advantage for geriatricians, and I had a geriatric practice as well, and Susan had a geriatric psychiatry practice, and Tracy's a real geriatrician. I assume you're a fellow, I don't know. But whatever the case may be, it's the social workers and the nurses, and occasionally Adrian pharmacists, who can really be helpful to patient care. Doctors have a limited role. It's all about getting families access to education, to practical advice, and to community resources, and that's what other healthcare professionals do better than doctors usually.
I totally agree, Peter. It really takes a village, I think, to provide the best care for these folks. The other thing that I would add is that this is a lot of the prevention work is bread and butter primary care. It is controlling blood pressure in midlife. It is encouraging your patients to exercise and not smoke and not drink too much. It's encouraging to prevent diabetes, or if people do have diabetes, to control it well. It's all of those things that we can do for the midlife person as well that will really help in the end to prevent the development of dementia.
And improve their lives in other ways.
Absolutely.
Mm-hmm. Mm-hmm.
I'm a big proponent of primary care, and I would say we have to integrate primary care and public health better. If we do that, then I think we really have a step forward in our healthcare.
I worked at the FDA for several years, and even before I did that, I wouldn't prescribe and don't prescribe any drug unless it's been out for 5 years or so. I wouldn't take any drug myself or prescribe any drug myself until it's been out about 5 years. Don't just say, oh, the FDA approved it, it must be okay. Wait and see what happens.
Thank you so much for viewing our continuing education activity. For more information and resources, please visit the Farmed Out website.